He is a zoonotic and vector-borne disease epidemiologist at the Washington State Department of Health in the Office of Communicable Disease Epidemiology. Her work focuses on zoonotic disease surveillance system design, implementation, and evaluation. And there's the title of her talk right up on the screen, so take it away.
Thank you, everyone. So I know in the program it says zoonotic disease updates, but we had so many updates that I decided to focus on vector-borne disease. But I did want to mention after Dr. Fraser's talk that we also have seen an increase in percent positivity of bats in the past couple of years, and it seems in Washington to be driven by epizootics in big brown bats. So I think we always deserve a pat on the back, but we'll see on this one. So by way of overview for vector-borne diseases in Washington State, here's a really busy table. So this points out the disease, whether it's ever been identified in locally exposed humans in Washington and whether it's been identified in vector species in Washington. So as you can see, we fairly routinely see Lyme disease, tick-borne relapsing fever, and tularemia, as well as West Nile virus in Washington State. Those are pretty common for us. Rocky-mounted spotted fever has a little bit more colorful history. We haven't seen a confirmed case of Rocky-mounted spotted fever in more than 2 decades. We see some probable cases, but the positive predictive value of those laboratory tests is in a bit of question. And then we have one identification reported to us by a researcher of Rocky-mounted spotted, or Rickettsia rickettsii, in dermacentor ticks in eastern Washington, but our entomology program has not found Rickettsia rickettsii in Washington ticks. Then you can see we have had locally exposed humans with babesiosis, but we've never identified babesia in ticks in Washington. And then we've seen anaplasmosis or Anaplasma phagocytophilum and Borrelia miyamotoi in ticks, but never in humans. We do have historical reports of both Western equine encephalitis and St. Louis encephalitis, but neither have been reported in Washington in more than 20 years. So this is a look at our West Nile virus cases reported between 2006 and 2018. So I think our past couple of years look fairly similar to your all. In 2018, we only had 1 case reported, as well as 1 presumptive viremic blood donor. And you can see we've seen some interesting shifts in seasonality. Historically, we always had peaks in mid-August, and then in 2015, we saw a peak earlier in July, and in 2017, our peak was in September. So we've started to see more variability in the seasonality of our West Nile virus cases. This is a look at animal surveillance, so this is both mosquito, bird, and horse mainly. And this map shows where mosquito trapping and testing occurs in Washington. So you can see we have some major surveillance gaps, and more than half of counties do not currently trap or test for West Nile virus in mosquitoes. We do have mosquito control districts in some parts of our state, as well as university partners who are helping out, and Department of Health traps. This is a look at some of the geography that we've seen, just some samples from recent years. So it was interesting that BC's case in 2017 was in the Okanagan Valley. We had cases in Okanagan and Spokane. Let me see if I can. So there's Okanagan County and Spokane County, and those are cases by county of exposure. And then over here you see our environmental detections. So those weren't really necessarily overlaying with our human cases, and part of that has to do with the lack of surveillance in different parts of the state. Compare that to 2015 when we saw human exposures more in south central Washington, which was much more consistent with where we were finding our environmental detections. But we do see differential geographic clustering of our cases depending on the year. 2018 was a very unusual year for us with West Nile virus. This represented our very first case of West Nile virus locally acquired in King County. King County is the county home to Seattle, and so a majority of our state population, not a majority, but it's our largest county in Washington state. And you can see our environmental detections this year did include Pierce County. That was the first time that West Nile virus had ever been detected in mosquitoes west of the Cascade Mountains, which follow this kind of county line down the middle of the state right there. And so that was also a really unusual detection for us. So in order to try to better get a handle on this differential, there's seasonality, there's geographic clustering, there's numbers of cases per year. It's really difficult for us to project risk in a given season, but we're trying to get a better handle on it. We started with California's risk assessment model that they currently use and kind of pared it down to use data that's available in Washington state. So this model attempts to project risk for the next week. So it's very short-term risk projections, and it uses average daily temperature over the previous 2 weeks, vector abundance, minimum infection rate in mosquitoes, as well as human and horse cases in nearby counties. We're currently validating this tool with historical data to try to implement it next season. California has had some success with it, and so we're hoping for good things. However, it requires data, and so in Washington state, we don't have a standardized system for reporting mosquito data, and so it requires a lot of manual entry on the part of mosquito control districts and other partners. A lot of counties, even if they're interested in starting up mosquito trapping and testing, don't have historical abundance data or testing data, and so there's a big barrier with lack of data. And then we want to project risk across counties, for example, like Okanagan, that don't have historical data. And so how do you project risk in an area just with missing data? I'm going to switch gears a little bit here and talk now about tick-borne relapsing fever and some interesting cases we've had recently. So TBRF is a disease that's caused by Borrelia hermsii, which is carried by a soft tick, Ornithodorus hermsii, which lives at high elevations above 1,500 feet generally, or 450 meters for you reasonable people on the metric system. These ticks prefer to feed on rodents, mainly squirrels and chipmunks, and the disease in humans is characterized by patterns of recurrent fevers, headache, myalgias, and arthralgias. So each year in Washington state, we have 1 to 12 cases of tick-borne relapsing fever reported, and you can see we have a pretty nice seasonal curve with our peak in August. Historically, cases were reported exclusively east of the Cascade Mountains. So even though Lewis County is colored in here, the case occurred right on the Cascade Mountain range there. And Okanagan County again and Spokane County are our 2 big hotspots for tick-borne relapsing fever. So in May of this year, we were notified of a Snohomish County resident who was hospitalized with suspected tick-borne relapsing fever. She had fevers, myalgias, headache, low back pain, and rash, and her provider had documented fever, hematuria, tachycardia, jaundice, and thrombocytopenia on admission. Her provider also reported that spirochetes had been seen on a blood smear, and the case reported a 2-night stay at a rustic retreat in Okanagan County. And so for us, this sounded like a pretty classic case of tick-borne relapsing fever. Her provider initiated ceftriaxone, and she became hypotensive and was admitted to the ICU in a presumed reaction to the antibiotics. And the clinician at that point had noted that the spirochetes on her blood smear were consistent either with leptospirosis or Borrelia, which I thought was a bit odd. And she was actually given a presumptive diagnosis of leptospirosis, given additional evidence of splenomegaly. No serologic testing was performed while she was hospitalized. She was discharged and then subsequently reported to public health. So the public health nurse who called to interview the patient was the first person to bring up tick-borne relapsing fever with her. And over the course of the case interview, the case was really focused on her exposures hiking, playing with her dog, exposures to mud, and drinking well water, which are all more consistent with leptospirosis than tick-borne relapsing fever. She really denied any ticks or any evidence of rodents whatsoever. And so at that point, we started questioning ourselves and wondering if it could potentially be lepto, which is also a spirochete that rarely in the literature has been reported to be seen on blood smear. She was very ill and hospitalized, and so it's theoretically possible. So we asked her to return to the clinic for a blood draw, and we split the specimen and sent it off for both leptospirosis and Borrelia hermsii serology. So it was negative for lepto and positive for Borrelia, so we were a little bit relieved by that. And given that this was a relatively large retreat facility that could house large numbers of people, we decided we needed to perform an environmental investigation on site. Again, she had reported no signs whatsoever of ticks or rodents during her stay. She did report sleeping in a bed pushed up against a wall, which is a known risk factor, and there were no other illnesses reported among her travel companions. So the main intention of our case investigation was to assess the likelihood that she had acquired her disease there, and thankfully the retreat voluntarily agreed to let us come inside. So our first lesson, and I think this is actually a pretty important lesson when looking at using case reporting forms for doing exposure analyses, is that cases may not be great historians, or the retreat may have looked very different when she was there, or people don't remember signs of rodent exposure, but this is what we saw when we walked in. So this is the fireplace mantle, that's some mouse poop there. This is a bed. That's a mouse carcass right there. The retreat had yoga, and so this is mouse feces by the yoga mats. It was kind of unbelievable. So that was an important lesson, that just because the case reports that there was absolutely no sign of rodents or ticks, that may not necessarily be what we find. So this is the room where the case slept. As you can see, the bed is pushed up against the wall, and you can just barely see it, but there's a little cubby door right there that leading to a crawl space behind the bed. And when we open that door, that's a mouse carcass, and this is all feces. So some pretty clear possibilities for exposure there. So Liz Dykstra, our public health entomologist, and I were on this investigation, and we wanted to see if we could find ticks. We'd never tried to find these ticks before. We knew that they could be in these kind of cracks and crevices, and so we put out dry ice on flannel, and we didn't catch anything. However, as you saw, there was plentiful signs of rodents, and so the epi evidence, both what we found and also her incubation and travel history, really strongly suggested that she was infected during her stay. And so for the retreat, we made recommendations about rodent cleanup, as well as consulting pest control about potentially doing some tick prevention on site. We also requested a list of everyone who had stayed there from the point at which she stayed there until present, to assess whether there were any additional cases and to look at ongoing risk. Unfortunately, the way the retreat was organized, they only had the names of people who had organized retreats and not everyone who had stayed there. So we identified 3 retreat organizers from Washington, Colorado, and New York State, and then contacted each retreat organizer to reach out and contact their groups. We drafted an online survey tool that was asking about dates of stay, their sleeping location, because there are a couple of different buildings on site, symptoms consistent with tick-borne relapsing fever and any antibiotic treatment. We did find 2 people who reported illness, but neither had fever or other symptoms consistent with tick-borne relapsing fever, and so did not find any other cases associated with this retreat. I'm just going to really briefly mention a second case investigation, which is very much hot off the press. So in September of 2008, Washington Department of Health was notified of a King County resident hospitalized with suspected TB/RF once again. This person had severe fevers that were cycling every 8 to 10 hours, which I thought was a little bit unusual, as well as headache and vomiting. Again, spirochetes were reportedly seen on blood smear, and she reported staying at her vacation home on Orcas Island the week before onset. Orcas Island is in the San Juan Islands, in case you're not aware of that. It's very close to your southern border there. She also reported glamping in Oregon 5 weeks before her onset. However, the longest documented incubation time for tick-borne relapsing fever is about 3 weeks, so that was really outside of her incubation period. We did ask about potentially other mild illness that was experienced before this course of more severe illness to see if her original onset date could have been earlier, and she really denied that. So the question for us at that point was, could it potentially be Borrelia miyamotoi, which can also be seen on blood smear, or can cause similar symptoms. We know that it's carried by Ixodes pacificus in Washington state. We haven't documented a human case, but providers don't really test for it. And that would just be a much more likely vector on Orcas Island. This map here is showing, I'm sorry, it's small and you can't really see it, but the gray is the known endemic range for Ornithodorus hermsii, and so it really stops in the Cascade Mountains, and Orcas Island would be up over here just south of Vancouver Island. However, when we sent specimens to CDC, it was confirmed as Borrelia hermsii by both serology and PCR and sequencing. So given the really unexpected exposure location of this case, we again decided to perform an environmental investigation on Orcas Island. And we also invited a Center for Disease Control Ecology team to join us as well. Our purpose was either to identify Ornithodorus hermsii or Borrelia hermsii on Orcas Island, since either one would be very surprising and unexpected. And with the CDC ecology team on board, we had capacity for both tick collection as well as rodent trapping, which rodent trapping is not something we would normally perform. This just happened last week that we were out there. It was a little bit cold. We didn't find any ticks, unfortunately, and our rodent testing is currently pending at CDC. So this is a story to be continued, but I think it has implications for our northern neighbors as well. So in conclusion, we've had some really interesting and concerning changes in vector-borne disease distributions in Washington over the past year, with the new identification of West Nile virus in mosquitoes west of the Cascades, our first identification of a West Nile virus case in King County, as well as a TBRF case likely exposed on Orcas Island. And these changes for us, the majority of our population lives west of the Cascade Mountains, and so it indicates that a much larger proportion of our population in Washington state could potentially be at risk of vector-borne diseases. And in the context of climate change and expanding ranges for vectors and pathogens, this is a big concern for us. So with that, I'd like to acknowledge the very many people, several of whom are in this room, from Department of Health, our local health jurisdictions, as well as CDC. Thank you.